Welcome to Navigators, a MedBridge podcast where we conquer challenging topics in neurologic and geriatric rehabilitation. Our aim is to deliver actionable takeaways for physical and occupational therapy providers like you through captivating discussions with influential practitioners in our field. To receive continuing education credit for this episode and access bonus resources, make sure to check out medbridge.com. Hello, I'm your host, JJ Mowder-Tinney, a physical therapist with over 30 years of experience working with people with neurologic deficits, as well as the aging adult population. I have multiple certifications, including being a board-certified clinical specialist in neurologic physical therapy and a certified exercise expert for aging adults. Today, I'm excited to be joined by Dr. Candace Tefertiller, an expert in the area of non-invasive spinal stimulation. We'll be diving deeper into this topic, including her recent research. She's going to share some valuable considerations and practical insights that you can start applying right away. Welcome, Candy. It's great to have you here.
Good morning, JJ. I'm excited to be here and I'm looking forward to our conversation.
Yeah, I've heard so many wonderful things about you, but I've never had the chance to actually meet you. So do you think you could get us started by sharing a little bit about yourself?
Yeah, absolutely. It's so nice to meet you this morning. So I've been a physical therapist for about 25 years. Most of my career has been spent in neurologic injury, so primarily treating individuals with spinal cord injury and traumatic brain injury. And most of my career, I have been engaged in research along the way and have always loved research. Said I would never go back to get my PhD, of course. And then about 7 years ago, I did. And so again, most of my career I've been doing research while I was a clinician, but now I moved over to research full time about 4 years ago. So love doing what I'm doing now, but primarily focused on interventions and technologies to maximize recovery after both spinal cord and traumatic brain injury.
And where are you located again?
So I am in Craig. I work at Craig Hospital in Denver, Colorado. I've worked at Craig now for almost 15 years. So I was the director of physical therapy here at Craig for about 10 years, and then moved over to research and full-time in research for almost 5 years now. So great opportunity to work in a great organization and love the patient population that I get to work with.
That's an amazing place. I think that's where I may have heard your name first, is way back in the more directors Craig. And then recently with your research, it's just been really exciting. And, the non-invasive spinal stimulation, that's very specific. I'm so excited you've gone back to really good dive into your research. But can you share what initially drew you to that specifically and how your passion developed?
Sure. So I have always been passionate about delivering intensive interventions that help maximize recovery after these types of injuries. So a lot of locomotor training in my background, different types of locomotor training using robots, using manually assisted treadmill training, different types of electrical stimulation. So just trying to find ways that we can increase excitability within the nervous system to facilitate that recovery after these types of injuries. And quite honestly, I was at a combined sections meeting quite a few years ago now, and I saw Reggie Edgerton speak at that time, and he showed videos of people with chronic complete injuries moving their legs in response to this stimulation that he was placing over their back. And I sat in the audience just in awe because I knew how hard I was working with every intervention we had in the clinic. And what I was able to do with those interventions did not meet what he was showing me, with what he was showing the audience with the videos that he presented at that conference. And so that was the first time that I really got excited about this idea of non-invasive spinal stimulation, and that maybe that was a type of intervention that could provide better opportunities for recovery than the types of interventions that I was providing in the clinic at that time.
Isn't it amazing? I mean, CSM, you can go there and it's just like, you go to some of these talks and you're like, oh my gosh, like I did not know this existed. Or, you just didn't know this was going on, and it just can totally change the trajectory of what you're doing. Just a shout out to going to some of those conferences, and CSM is a big one.
100% agree. Sometimes when there's 20,000 PTs all running around the same area, it can feel a bit overwhelming, but the content is so incredible. And I can say that I go to CSM every year, and every time I go, I come back with something that has has changed me in some way and challenged me and provided me with more questions. And so for that particular CSM, transcutaneous or non-invasive spinal stimulation was really this question about if this is really true, what I'm seeing on these videos, then I want to investigate it. I want to understand it. I want to know if we could be providing more opportunities for recovery than what we're currently doing in our clinic. And so quite honestly, I reached out to Reggie when I got back to Craig and said, hey, can I come and spend the day with you and just see in your lab what you're doing? And he was incredibly kind and gracious. And he let me come and spend the day with him. And I was really impressed with what I saw. Again, I've been treating people with spinal cord injury for over 20 years. And I knew that what I was seeing in that lab was not something that I was able to do necessarily in the clinic at that time. And so I asked him if he happened to have a stimulator that he would let me do a small pilot study here at Craig. And he, again, was kind enough and gracious enough to give me a stimulator to do a small pilot study here at Craig. And at that time, we were heavily involved in intensive manual locomotor training, and we were doing it in a systematic approach through the Neuro Recovery Network. And so I was also excited because I knew that we were providing this very systematic approach to locomotor recovery and that we were collecting outcomes in a very systematic way. And so if I added stimulation into what we were already doing and I saw a greater benefit, I felt very confident that the benefit was actually associated with the stimulation and not just some of the random variability associated with clinical practice. So when I got back, I looked for individuals who had already completed our intensive outpatient locomotor training program, had plateaued in recovery, and enrolled them in a pilot trial where I combined spinal stimulation with the type of locomotor training they were receiving in outpatient therapy.
Oh, nice.
And we had 7 individuals who completed that trial, and we saw significant improvement above and beyond what they had achieved during the regular outpatient therapy program once we added this type of stimulation into their therapy. And so again, that really encouraged me that there was some mechanism behind increasing the excitability of the nervous system that we had not been able to tap into with the intensive locomotor training that we had been providing them.
Wow. I mean, you just said a lot, and that the importance of this topic, you kind of hit the nail right on the head. So there's a lot of research out there on this, or what's the status of?
Yeah, no, the research is still pretty limited, quite honestly. Most of the research to date has been case studies or pilot studies that have not included an alternative intervention arm. So there really hasn't been any large comparative effectiveness studies yet, which is one of the challenges with clinical translation. And so we've seen very nice preliminary evidence that when you add spinal stimulation on top or augment the training that we're providing in the clinic with spinal stimulation, the effects, in my opinion, have been better than training alone, both in the upper extremity and in walking retraining. So there's been there's been quite a few case series published to demonstrate this improvement in walking speed, walking endurance, a decrease in spasticity associated with spinal stimulation as well. And then we also recently published a multi-site clinical trial evaluating the upper extremity effects of pairing spinal stimulation with functional task-specific practice. In a chronic population, we had 65 individuals who enrolled in that trial across 14 sites. And we did see significant improvements in both strength and function in 72% of the individuals who enrolled in the trial, even though they were chronic injuries, and we would not have expected those kinds of changes.
Wow, you've been busy. Now, so this is really fascinating to me because there's just so much great things happening, I think in the neuro rehab world of, this and then layering in this and then layering, and then we learn about this or layering in this. So this is just really exciting. But I have to admit, the spinal stimulation is one of those topics where I feel like I don't even know what I don't know, which honestly is exciting to me because I just love to learn new things. But I have a lot of questions. So, and I'm wondering if the listeners feel the same way. So if you're new to transcutaneous spinal stimulation, because that's what we're talking about, right? Don't worry. Mm-hmm. This conversation is for you too. So I'm excited for you to kind of break it down for us. So do you think, so talking at my level, do you think you could break down the mechanism behind the transcutaneous spinal stimulation? Because I think that's the big difference that I'm not as familiar with.
Yes. So one, we don't know for sure exactly how it's working, but there is a hypothesized mechanism. And so we're essentially taking electrodes, replacing them right over the spinal cord, generally in between two spinous processes, and looking for the areas of the spinal cord that are most related or most responsible for directing motor output in the areas that we're looking for recovery. So specifically, if we are looking at upper extremity recovery, we are generally putting the electrodes somewhere between C3, C4, C6, C7, and we are essentially, and then we're putting the return electrodes either over the anterior iliac spines or over the clavicles, with the idea that we are trying to direct that electrical current right into the back of the neck or into the back of the lower back, that serves those plexuses that really are responsible for both upper extremity and lower extremity activation. And if you think about spinal cord injury, it's an electrical problem, right? We can't get the electrical signals all the way through to the peripheral nerve system to activate the motor units in the way that we did before the injury. And so this type of stimulation, we're putting it right over the back of the spinal cord. We are driving the stimulation into the posterior aspect of the spinal cord, and those primary afferent fibers that go into the back of the spinal cord, we're essentially turning up the volume or increasing their excitability so that when they go into the spinal cord, they're sitting at a higher level of excitability, and then they can either directly synapse on the spinal motor neurons or synapse on inner neurons within the spinal cord. But the really important point to know is that they are essentially lowering the resting threshold of the neurons within the spinal cord so that even a weak supraspinal signal could activate motor potential, right? So those neurons are sitting closer to activation potential so that if we can get a weak signal in there, they should be able to activate motor movement. So the way that I kind of think about it is that the propriospinal system is a critical pathway in this mechanism. And if we remember just back to basic physiology, that goes all the way down to our peripheral muscles. So the muscle spindles that are in our legs are being stretched, and we're monitoring the rate of activation. And that sensory signal is going all the way up the spinal segments into the cord. And that is the where we're trying to turn up that volume, so that we have an increase in excitability within the spinal cord so that it's more responsive to any sort of signal coming down from the brain to drive voluntary movement.
Wow, that was a beautiful explanation. That kind of makes me think a little bit of like high intensity kind of primes the brain, and this stimulation is kind of priming the discussion and the ability to take more through the spinal cord. I know that seemed real simplistic, but
no, that was beautiful. It's another way to prime the nervous system to turn up the volume so that it is more responsive after there's an injury. That was a beautiful way to think about it. It's just another priming mechanism, but I believe that it's a way to directly intervene into the posterior roots that are going into the spinal cord, which include that propriospinal pathway, so that we can get some direct motor activation with much less of a descending signal than what we can get without it.
And I love the thought. I mean, it's transcutaneous, right? So It's not like we're having to go surgically implant anything. You are doing this. It's non-invasive.
You're exactly right. And that brings up another interesting point, is that the literature at this time would tell us that we are activating the same common neural mechanisms when we do non-invasive spinal stimulation that we do with epidural stimulation, in which we are implanting the electrodes right on the spinal cord.
Oh, wow.
The difference between the two is that when we do it non-invasively, you get a much broader spread of the electrical current. And so you don't have as much ability to specify specific posterior roots that are going to be active. You kind of get this broad spread of current. And so then that requires a lot more total current to activate within the spinal cord. It's just not as conductive when you go through the skin, right, to get the current in there. Versus in comparison to when you have the electrode right on the spinal cord, you're activating the same pathways, but you can do it much more targeted and much more specific. So I 100% agree with you that when we think about our two ways to activate our two spinal stimulation pathways, you've got non-invasive, which is what we're talking about today. So there's not a surgery involved. There's not the risk for infection associated with the surgery, and there's not the resources that a surgery would require in terms of financial resources and time and all those other things. And it activates the same pathways, but it just requires more stimulation, and it's more broad-based than what we get with epidural stimulation, in which we're implanting the electrode directly on the dura.
Well, I mean, so just like anything, there's no perfect solutions. There's only trade-offs, right? So,
yep.
But the great thing is to have more options. Having more options is important. And I keep thinking like the broadness of it is what we need for upper extremity function and for walking. I mean, there's a whole lot that we need to activate. So that's pretty interesting. But I'm curious, you have to turn it up. You're saying it has to be at a higher level to be able to go through the areas it needs to go through. But so how do people tolerate that? Are the people you're working with your subjects doing well with that?
Yeah, that's a great question. And that's one of the areas that we're honestly still trying to understand. Some people tolerate spinal stimulation extremely well. And really, I think a lot of it depends on their initial injury and how interrupted that sensory nervous system is. And then some people find it to be uncomfortable, especially in the cervical area. So when I've done quite a bit of cervical spinal stimulation for the upper extremities, and there are some people that you can get a really great motor response, but they can't tolerate training at that level to maintain it. And then there are some people who could go up even higher than what you need in order to get that response. So I think, it's, the heterogeneity of the population is what we're always going to face. And just like you said, it's another tool that really may benefit some people, but won't be the fix for everyone.
Well, you find that even in muscle stimulation, I can use the same just blank stimulation on someone's wrist extensors and they're like, woo, and you hardly turned it up. And other people, you have it way up there and they barely respond. And I'm like, but it's set exactly the same. So, just baseline and then to add the complexity of an injury in the area, I think, that really is. But so first you have to figure out, does this even work? Right. And then you have to figure out who does it work for and like what settings are required to make that work. Right.
Yes. One thing that you just made me think about, I think is really interesting to think through, is the difference between peripheral nerve stimulation and spinal stimulation. And that's one of the things that I think if the people who listen to this podcast come away with the difference between the two, I think that would be really valuable. But essentially, in my mind, when we stimulate with a neuromuscular stimulator or any type of peripheral nerve stimulator, you are driving current into that peripheral nerve. And once the all or none principle, once you get there, all of the fibers below that peripheral nerve or that are close to that peripheral nerve are going to activate, and you're going to get motor activation, whether or not you want it, whether or not the person is trying, whether or not they want to be activated. If you get enough current over that peripheral nerve, those muscles are going to fire, right? And that is a very different mechanism than we're talking about with spinal stimulation. So with spinal stimulation, we're just trying to enable the spinal cord to drive voluntary movement when there's less signal that can come to it. So if I turn up the spinal stimulator, I am not turning it up to the point where I see the hand automatically move. I'm just turning it up to where I see maybe some twitching in the hand. And then when the person sends a signal to try to move the hand, it should enable greater voluntary movement of the hand, but it's not going to force the hand to move. Whereas, again, with peripheral nerve stimulation, you turn up the current and the hand, you're going to get wrist extension whether you really want it or not. And so I think that's a big distinction between the stimulation that most of us are really comfortable with which is peripheral nerve stimulation, and what we're trying to do with spinal stimulation. And that's just trying to raise the excitability in the cord so that it's more responsive to the signals that are coming down from the brain.
No, that's really, really helpful. Especially, as a therapist, it's interesting because your patients and their family members, they look up everything.
Yeah.
And if they look up some of these and you're like me, and I was like, I'm not as familiar with this direction, and where's the research at? And, we'll talk about some other things from like availability. We as therapists, we kind of have to have a finger on the pulse of what's going on so that we can help communicate and educate people who are out searching. So that's a really, I love the way to explain that, just in case they're looking at things or looking up things, for us to be able to delineate that out. So that is very helpful.
And that's a really good point. Our patients know, I was just going to say, our patients know everything that's out on the internet. And so being able to just educate and explain, I think is such a valuable tool that we need to have.
So so where was the original researcher that you talked about?
So Reggie Edgerton is a researcher at UCLA who's very well known, who's very well known in spinal stimulation. And he's kind of the one in my mind who has really pushed this forward for people with spinal cord injury.
Very nice. And so you're doing some research. Is this only at the research stage in research labs? Is it commercially available? Like, are there other therapists out? Like, what's the status?
Yeah, that's such a great question. And I don't have a solid answer for you. So right now, the work has been primarily focused in research. And most people are really trying to understand who does this benefit and what are the parameters that we need to be using to get maximum benefit. So there's a group in Austria who's done a lot of this work, and the Manassian group, and they're doing some really amazing things, and trying to understand, do we need neurophysiology to optimize our parameters? Meaning, do we need to be able to see that when we stimulate, we can pick up motor activation with EMG at a peripheral muscle group? Is that the way we should be setting our stimulation parameters? Or is it more similar to what you and I know in the clinic? You turn it up until you see some sort of sign of excitability, and then that's where you should train at. And so there's still just a lot of unanswered questions about how to optimize this type of stimulation. But there are several research groups around the world who are really focused on this right now. There is not yet a stimulator on the market that has been specifically designed for non-invasive spinal stimulation. There is a stimulator, I believe, the company believes will be on the market in the near future that was specifically designed for spinal stimulation, but that is not commercially available yet. On the flip side, I do know that there are other clinical facilities and research facilities that are using off-the-shelf neuromuscular stimulators to do the same type of thing. So they are using even the little handheld stimulators in the clinic. They're putting it over the spinal cord, and then they are augmenting practice with that type of stimulation. So it's a little bit uncertain right now. Whether or not I don't know of the benefit yet of using these off-the-shelf stimulators to do the same kind of thing. My one, not concern, but my one question about that is that most of the off-the-shelf stimulators don't go to a frequency, or you are not able to get to a 1 millisecond pulse width with those types of stimulators. And that the literature has suggested that type of pulse width is what primarily activates those primary afferent fibers going into the spinal cord. And so if we believe that that's the mechanism behind spinal stimulation, then we really need to be stimulating with stimulators that go to at least a millisecond pulse width. And there are very few stimulators on the market right now that have the availability to do that.
So just to recap a couple things here. So you're saying, are the clinics, some people who are out there using just off-the-shelf stimulators, they're doing research with that, or they're just trying
They're
it
just
out?
trying. Yep. And honestly, I hear about this when I present at conferences. People will come up afterwards and say, "Hey, I've been putting a stimulator on the back of my patient's neck when they've been doing upper extremity training or when we've been doing walking, and I think it's really helping them." And it very well may be. I certainly don't know whether or not that's true. But I think, when we think about the mechanism that we believe is happening with spinal stimulation, we really should be stimulating at least a millisecond to be active and, to be preferentially activating those primary afferent fibers that result in that reflex activity or raising that excitability within the nervous system.
Okay, so as a therapist listening to this, your patient asks about it. They, you never know what people are selling out there either. So, they may be buying something and doing something. So I think, that's an important piece just to make sure that we're all clear on that, and the level that you need to be able to really make sure that's beneficial. Do you see any, concerns in regards to them doing this?
I think my only concern would be monitoring the skin, like we always do with any type of stimulation, right? We need to make sure that the skin underneath those electrodes is staying healthy. And as long as the patient is tolerating it from a sensory standpoint, the skin is staying healthy. I don't see any direct concern for harm with doing it. I just don't know that we have enough data yet to really tell us whether or not that's going to be more beneficial than training alone. So I don't see that it will be harmful in any way, as long as you're monitoring the skin and monitoring your patient's tolerance. We just don't have the data yet to support whether or not that is the optimal way to provide spinal stimulation.
And I just think that's a really important point for therapists to be making. If your patient is coming to you asking you to do some of these things, this given what is required to make the environment optimal, this machine probably doesn't do it. And there's no research to support that yet. But, positives are there's a lot of things, you're still researching it and it's still coming out. Right. So, just want to make sure people so if someone was, because I'm always hesitant because you don't want people to just go out and start doing things willy-nilly, right? Especially when they're, taking an idea and then adjusting it.
Yeah.
Because we want it to be specific. So if someone is already doing that or they're thinking about it just interested in this topic, so where are some of the, the trials and the case studies, what recent research could they go look at so that they could understand that better, especially the setting requirement and, how this is very specific?
Yeah. So the Manassian group, so MINASSIAN, they have quite a few papers published that help identify these stimulation parameters. But again, they focused primarily on using neurophysiology measures to identify them, and most clinics don't have that skill or that equipment to do that. There's a paper that was published out of Shepherd Center in Atlanta. Estes is the primary author, or is the first author, and they actually used one of the off-the-shelf stimulators that the pulse width goes to 400 microseconds, and they combined walking training with that type of stimulation over the thoracolumbar area, and they showed a benefit to walking training with that stimulator, but they didn't show a significant difference with walking training alone. Now, they had a very small N. They were not powered to find a difference. So it's all the same challenges we have in our research, especially in spinal cord injury with such small numbers. But they used an off-the-shelf stimulator. They stimulated in much of the same way that we would with using a peripheral nerve stimulator, and they did it in combination with walking training. And they did see people with subacute spinal cord injury improve their walking ability. There's a paper out of Baltimore, out of Kennedy Krieger. McHugh is the primary author on that paper. And they also demonstrated improvements in overground walking in combination with an off-the-shelf stimulator. I believe in 10 individuals with chronic spinal cord injury. again, they didn't compare it to any other intervention. And so we don't know for sure that it was better outcomes than they would have achieved without the spinal stimulation. But those are a few papers that could kind of give people some idea on how to use that type of stimulation with an off-the-shelf stimulator.
That's really helpful, Candy. Maybe we can give that to the producers to put into the notes,
Sure.
just so people can link there. Because, I guess my dream is like a group of people could listen to the podcast from a facility, assess what are they doing, what aren't they doing, learn some more, and then have the research to be able to go explore deeper into the evidence. And then maybe, I don't know, are you presenting at CSM this?
I am. And so I had two spinal stimulation talks last CSM. And then I have a talk this year on our exoskeletons, but I don't have one on spinal stimulation this year.
So, but just to keep an eye on you also. So as they're developing in that, because then they can start thinking about so you talked about the patient diagnosis, but is it just improving walking and upper extremity use?
Yeah.
Impacting any other kind of impairments that we commonly see with this population?
Yeah, great question. One part of that quite honestly took me a while to get my head around is that when we're increasing excitability of the spinal cord, we're increasing excitability in both inhibitory and excitatory circuits, right? So for the longest time, I kept thinking we're just exciting. Well, we are exciting, but those inhibitory circuits are also being excited. And so when we think about one of the primary challenges that people with spinal cord injury have, it is often spasticity. And so there's a couple different papers already published that suggest that non-invasive spinal stimulation also reduces spasticity along with improving voluntary motor function, which completely makes sense. But I think the word excitation for a while was just clouding my understanding of it. And so when we think about who benefits from this right now, I have a stakeholder advisory group that we created of people who we've used non-invasive stimulation with over 60 individuals here at Craig throughout our different studies. And so I've created this stakeholder advisory board so that people who have already been stimulated can help me design and implement all of the trials that we're doing moving forward. And so I just had an advisory group meeting last week, and they reminded me of some of the benefits that they have reported or that they believe are associated with their participation in some of the studies. And they've included one of the first topics that came up was a decrease in spasticity. So people with increased or with incomplete spinal cord injury have reported that they type faster and that they're able to better get their buttons fastened, their pants fastened, all of those fine motor activities after they've participated in some of our upper extremity studies. One gentleman reported that prior to participating in the study, he was not able to stand or walk independently, so he wasn't able to transfer into his truck on his own. And after the study, he was able to load his wheelchair in the back of his truck, walk along the side of his truck, and then get into the truck independently. So another individual reported that he had not been able to, I know, isn't that great? Had not been able to get to all of his son's soccer games because it was too difficult to get his manual wheelchair across the grass, and he didn't have the endurance to walk with his walker across the grass to get to his son's soccer games. And now he's able to do that without any difficulty, not without any difficulty, but he's able to do it consistently and doesn't have to worry about whether or not he's going to make it. So those are some of the benefits that we've seen from reported benefits from people, not the outcome measures that we've tested, but what they're telling me has really changed in their lives based on some of their participation. And then in terms of the other benefits.
Sorry, there's a couple things in there I want to unpack for a second. And I'm sorry to interrupt you, but first of all, right now there's this big, emphasis of, are we really making an impact on their participation in people's real world, the things they need to be able to do every day to actually improve their quality of life. So those are really great, descriptions of the impact. And just from the spasticity standpoint, I mean, we know that is a thorn in therapists and obviously patients, but side, you just want to so much help them. And I always think about, like, I really aim for the strengthening part. Like, can we get them stronger than their spasticity? That makes so much sense that if you're stimulating the excitatory to actually get movement, and then the inhibitory is also helping it its own impact. I just think that's huge in regards to the potential moving forward. I just hope that it continue to, move on that, because that spasticity component is just, we know the impact on people's quality of life is huge. And for some, it's just the biggest limiter. So sorry, you're going to tell another one, but I was just like, kind of highlight those two. That was really impressive.
No, and honestly, exactly what you said. We if we remember that reciprocal inhibition mechanism, if you get one group stronger, it's sending inhibitory signals to the antagonist group, and that's exactly how the nervous system is supposed to function. And so by increasing excitation in the inhibitory circuits, while also increasing excitation in the excitatory circuits, we're just reintegrating that reciprocal inhibition reflex and, really trying to get the nervous system to respond in the way that it did before the injury. So I think the only thing I was going to say is that there are all additional studies that suggest that spinal stimulation may be beneficial in improving bladder function after spinal cord injury. We participated in a multi-site trial here, have not analyzed the data yet, but the company is currently analyzing the data. And I'm excited to see if that might also be an indication for spinal stimulation, because we also know that bladder and bowel function really inhibit somebody's ability to get in the community, to be confident in the community. And so doing something to improve bowel and bladder function would be amazing.
Yeah, that is. I just remember, like, 25 years ago, ish, going to Cleveland Clinic, for a course on the, but that was more implants and looking at some of this potential with implants and bowel and bladder, and just to think that potentially, we might have something that's more superficial or non-invasive is just, I think, really exciting. And so, boy, you must be excited. You're like right on the cusp. I love the cusp of the edge of the wave. When you're thinking about where you're at and how it led to be. So just thinking about our listeners, and, I think, a big heavy hitter that I'm just trying to emphasize is the understanding, the knowledge of this and where things are going and what to keep our eyes on. But the caregivers, I know I keep going back to that, but and the patient asking questions. Like, if you could just, like, what do the therapists need to consider, in regards to that? Like, what would be your biggest talking points specifically for them? Not even our actionable takeaways, but specifically for them. Are there any, could you just summarize that for us? I know you've said it kind of throughout.
Yeah. I think the big thing is just being able to explain the difference to patients and families who come in and they've heard about spinal stimulation, being able to explain that non-invasive spinal stimulation is putting electrodes on the skin over the spinal cord, trying to drive current into the spinal cord to increase excitability so that they can better activate their muscles on their own. Versus peripheral nerve stimulation is putting electrodes over a peripheral nerve and forcing it to activate muscles that are, associated with that motor unit. I think being able to describe those differences would be really valuable to any therapist who's in the clinic. There's been a lot of discussion or a lot of media associated with spinal stimulation. And so I think most people with spinal cord injury have been interested in it, or many people have been interested in it, know about it, and have questions. And so that would be a first piece of it. I think the second piece, being able to explain that most of the off-the-shelf stimulators right now don't necessarily have all of the parameter adjustments that we believe may be the most optimal environment for providing this type of stimulation, but we don't know that for certain yet. There's not been enough literature or data reported yet to really identify what are those critical factors and how do we set those parameters to ensure they maximize recovery and maximize output. And I believe that the off-the-shelf stimulators, as long as they're used in a way that we would generally use them for peripheral nerve stimulation, I also don't believe they demonstrate any greater risk of harm. So I don't think it, as long as you're monitoring the skin, as long as you're monitoring the patient's tolerance, there's nothing that I know of to believe that that's going to cause anybody harm. It just may not be the most optimal way to stimulate the nervous system. And yet we're still figuring out what's the most optimal way to provide non-invasive spinal stimulation. So I think those would be my take-home points.
Yeah. And, it just made me think of something. Also, because I'm all about, you only have this much time with your patient. Like if you end up spending time fussing around with something that you don't really know if right now, because you have it off the shelf, you don't know if that's going to work, you don't know exactly where to put it, you end up spending a lot of your chunk or the little chunk of time that you already have with your patient working on that instead of just doing the function and trying to get the intensity and trying to get the movement. You have to weigh that. You have to decide, is that really worth it? Or do they need to, that needs to go down a different path, at least for right now, until you have more information. So I think that might be another option in regards to explaining it to your patient that you only have this much time with me and we want to optimize every second of it, So I just think that's so important. Sometimes I'm always like, if you're messing with a peripheral stim, if you're messing with it and then you're spending more than a couple minutes and you're frustrated, and just leave it. See what you just let it stay there. Yeah. Don't worry about it and go about going all in with your intervention, I think is also another, option when you think about that.
Absolutely. And patients get so frustrated when, those every single minute in therapy is valuable, right? And patients and families get frustrated too when you spend time trying to get technology to work and, they're not getting their therapy and they're not getting their training. And so it certainly is a balance, and everybody needs to make, I think, that's where educating your patient, having a discussion about what their priorities are, what's most important to them, and then coming up with a plan together is probably the best option right now until we have more data to support how to use spinal stimulation.
Yeah, and you have to justify to whoever's paying you, like, what are you doing in that time frame? And so just these are things to keep in consideration. But I'm just, if you think about just how far this research has come, that has to be pretty exciting. So just from a clinician standpoint, like we always have our 3 big actionable takeaways for clinicians. And I know we I made you kind of focus on the family asking about that, but are there other big key heavy hitters that you want to make sure that the clinicians are remembering about this topic?
Yeah, I think just maybe really trying to, look at the literature that's coming out and making sure that you're staying on top of what's available and what's coming out. And that can be really hard as a primary clinician, right? I was a primary clinician for many, many years, and you got a full day load. And so I completely understand it, but finding different ways that you can ensure that maybe as a team, you guys are doing journal clubs every month or something like that, especially if you're treating people with spinal cord injury, maybe an ongoing journal club about what's happening in spinal stimulation might be really beneficial. Things are changing fairly quickly. And then I think that would be really beneficial from the big picture standpoint. And then I think, if you're a clinician that hasn't used peripheral nerve stimulation very much, maybe, getting a peripheral nerve stimulator out and, getting it on somebody, maybe your teammate next to you, and practicing on how to use peripheral nerve stimulation again might be really beneficial. It's interesting to me because I've used stimulation my entire career, but I meet so many clinicians, and no judgment. We all have our different tools that we go to, but so many clinicians don't necessarily use even peripheral nerve stimulation. So getting more comfortable with that again, might be a really good idea. And then just being open to new advancements and new technologies, and, ensuring that, we're investigating, that you're investigating what options there are out there that might benefit your patients. I think that's one of the most exciting things about being a PT, right? Is there's always change and there's always opportunities with new interventions coming out, and making sure that you're staying on top of that, whether it's spinal stimulation or anything else, I think, is really important.
Well, I think you just brought up some really good points. I'm one of those therapists, by the way. I represent that remark of not using STIM. We just never had it when I was in the clinic. And I mean, even growing up in my mom's PT clinic, I should know how to use STIM. And it's not that I didn't, it's just that the university, we didn't have that at the university. And it was just felt like a time consumer. And I think you just bring up this excellent point, then you have to decide, you learn more about it and decide what are you going to advocate for, and try to get a system. Think specifically about where could you use it and how could you use it. And I love that idea of, maybe they can listen to the podcast first, and then they can do the article review, and then they can spend just 10 minutes at a luncheon, putting it on each other and being specific with what would you have the patient do while you did this. Yep. This isn't just about, right? I mean, you are just stimming and then walking away. Like you said, you're stimming and then they need to do the functional task. And so it always kind of comes back to making sure we know what you said, what do they care about and what's the task specific activity and those things. And that's why I love the cases or the examples that you brought up in regards to that. Did you have any other case? Did I let you get through all your case scenarios, or did you have other ones you want to do?
Yeah, I was going to bring up a couple of the people who shared comments earlier. Those were a couple of the cases that I learned the most from, quite honestly, in doing some of this research. One of the young ladies, she came in with a motor complete spinal cord injury. We'd already done, 80 sessions of locomotor training. We had done a lot of peripheral nerve stimulation, and she still didn't have any voluntary movement below her injury level, which was C6. And then after about 18 sessions of doing spinal stimulation, she came in one morning and said, "Hey, Candy, I think I moved my leg to help me roll in bed last night." And I said, "Well, I don't know how you would have done that because the stimulator wasn't on." And she said, "Well, I think I can show you." And so I transferred her over to the mat, and she was able to pick up her left hip.
Oh my God.
I know. I couldn't believe my own eyes, honestly. But she picked it up 10 times against gravity before we turned the stimulator on. So that got me really excited that not only can people potentially improve their motor performance while the stimulator is on, but that they also may see carryover effects after training and strengthening those pathways that they can hopefully utilize for function even when the stimulator is not being used.
Oh, wow.
So she was one of the first people who I saw that happen with. And then the other gentleman was the person that I spoke with, or that I spoke about, who walking to his son's soccer game became much easier. And, he's somebody that has a lot of spasticity, both in his hands as well as his legs. So he's able to walk, he's able to use his hands, but his function is significantly limited by spasticity. And so again, I don't know that we saw we didn't see huge increases in strength when we measured strength changes from him, but we saw really significant increases in function. And I believe that's because his spasticity was reduced and he was much more functional with his hands and his walking because he wasn't fighting all of that spasticity. So those were just a couple of cases that I thought, really taught me a lot about how spinal stimulation may be beneficial to people who have very different severity levels and very different presentations in the clinic.
That is, I can see why you got so excited.
Yes.
To go back and get your PhD and to do your research, that's impressive. And I could see why. And I'm really, really grateful that you're out there doing that, because that is really exciting. And, I look forward to continuing to watch, where this is going. As I look at our time here, I wanted to give you a minute to see if there was anything that you wanted to close her up with in regards to words or inspiration, anything you want to leave with the audience?
Yeah. I think I would just say, I love being a PT. I think we have such a great opportunity to impact people's lives and to really partner with them when they have these types of injuries so that we can, kind of act as their guide, but also really their advocate as they manage this injury and try to get back to the lives that they were leading before or something similar to that. And so I guess, I would just say that we're lucky to be able to do these types of jobs. And I'm thankful that I am a PT, and I also now am grateful that I get to do research to better inform our practice. And so I just, maybe put the challenge out there that I know how difficult it is to be a primary therapist and stay up on the literature. But again, maybe find a group that you're working with and find ways that you can do it from maybe a low burden standpoint, but yet really stay up on what the literature, stay current on what the literature says about how to help people recover, and then stay open to trying new interventions, again, knowing that our primary goal is to do no harm, but that as long as you know you're not going to be doing harm, try new things and really advocate for people to maximize their recovery after spinal cord injury.
That was beautiful. Oh, thank you so much, Candy. Well, that wraps up our conversation today. Candy, thank you so much for sharing your insights and expertise on non-invasive spinal stimulation. It's really been fascinating. And to our listeners, thanks for tuning in. We hope you found this inspiring and informative as we did. Thank you, Candy.
Thanks, JJ. I enjoyed it and I appreciate the time.
Thank you for tuning in to this episode of Neuro Navigators by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Neuro Navigators also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com. As we wrap up today, remember that your dedication makes a difference. We appreciate you being here to navigate these topics and hope you enjoyed our deep dive into everything neuro. See you next time.